We are your hosts, Nikki Shore and Jesse Swain, and you are listening to the American Journal of Infection Control podcast, Science into Practice, brought to you by the Association for Professionals in Infection Control and Epidemiology to highlight work published in our peer-reviewed journal, ACHIC.
Join us as we speak to those in the field of infection prevention and control, like us, as well as other experts, to learn about some of the latest research in the field and how it can be put into practice. We hope you will listen in, learn something new, and apply this information to your work. If you are not a researcher already, we hope this podcast will get you thinking about areas where you can carry out your own research.
Jess, how are you?
I'm good. How are you?
I'm good. I had a wild weekend. Don't ask me how, but I ended up cleaning my house and labeling all my spices. And I gotta say, I felt like the infection control police with all those expiration dates.
I think that's really funny because I recently just admitted that I actually label things when I open them.
Oh, do you at home? Seriously?
So I know when to throw them away.
Oh,
yeah, I do.
That's funny.
Yep.
That is funny.
Mm-hmm. Yeah, these are the kinds of weekends we have when we're adults.
Yeah, you know what? Next thing you know, you're going to be auditing hand hygiene compliance at parties.
Well, we do it sometimes in restaurants.
Yeah. Well, just don't tell anyone. You know, be stealthy about it.
Right.
You got a joke for me?
I don't have a joke for you.
Okay, I've got one. Why don't bacteria ever get lonely?
Why?
Because they're always hanging out in groups, like staff meetings.
I thought you were going to say because they live in colonies.
Oh, there you go. Yeah.
Like
Who knew microbes were so social? But welcome back, everyone. You know, today we're going to be diving into some fascinating findings on infection control and transmission dynamics. And as you know, we're always ready to break down the science with a little bit of fun along the way. Today, we're talking with Dr. Michael Charness, Dr. Kalpana Gupta, and Dr. Katherine Linsenmeyer about their article, Evidence from Whole Genome Sequencing of Aerosol Transmission of SARS-CoV-2 Almost 5 Hours After Hospital Room Turnover. So, Dr. Michael Charness is a chief of staff at the VA Boston Healthcare System, where he oversees clinical care, education, and research. He is a professor of neurology and associate dean at Harvard Medical School and Boston University Chobanian and Avedisian School of Medicine. His research background is in cellular neurobiology, and his recent work has focused on the response of healthcare systems to the pandemic. Dr. Gupta is the Associate Chief of Staff and Chief of Infectious Diseases for VA Boston Healthcare System. She has a research program focusing on the epidemiology and prevention of healthcare-associated infections, including respiratory, urinary tract, and post-surgical infections. Dr. Katherine Linsenmeyer is the hospital epidemiologist for the VA Boston Healthcare System, and her work focuses on the implementation of prevention measures to reduce hospital-acquired infections, including COVID-19 and C. diff. So thank you guys very much for taking the time to talk with us today. So I don't know who wants to kick us off, but can someone just give us a little bird's eye view of the study and why you did it?
Maybe I'll start. So the reason we did this study is because we were trying to learn something about infection prevention from an outbreak. Everybody had hospital outbreaks during the pandemic, and this was an outbreak that occurred in July of 2021, which was the time when the Delta variant was predominant. And we learned a couple of things from this outbreak. The first was that it spread largely among patients on a particular unit, and our hospital epidemiology group traced everybody who had contact with those patients, and 168 contacts, all of whom wore masks, did not get infected. And we thought that was significant enough to send a note into the New England Journal. But we also, because VA makes it easy for us to sequence virus when we're dealing with outbreaks, started to look at the sequencing data on the people who had been infected, and we saw something very interesting. What we saw was that, as you would expect in an outbreak, there was near sequence identity among all of the people. There were a total of 8 people involved in this outbreak, which meant that they were likely infected from the same source or infected each other. But we could divide the 8 people into 2 groups of 4. The first group of 4 had a particular single mutation difference from the second group of 4. And in looking at what we thought was the direction of transmission, there was one patient who had been walking around the unit without a mask, and we thought that that was likely the person who had spread it to at least the first 3 people. All of those people, plus this person, had the same identical viral genome. But the second group all differed, and they had what we would call a reversion mutation, which is to say that if you look at just one nucleotide, it was different and had reverted back to what the original lineage had been. And so it looked like those 4 people had all been infected by one person who experienced the reversion mutation. Now you could ask yourself, well, maybe one person had infected the others, or maybe that person who wandered had infected each of these individuals, and that they separately underwent the same mutation. But with 29,000 plus base pairs, to have the identical reversion mutation in each of these individuals was extremely unlikely, statistically almost impossible. So then we looked at when people had gotten into the room, and what we were really startled to find is that the first person who underwent the reversion mutation was actually discharged from their hospital room before the next 2 people who were infected with exactly the same genomic DNA, RNA. And so we were curious, what was the time lag? Because, for a number of years since the start of the pandemic, people have been asking the question, so how long does my aerosolized virus stay in a room and put people at risk after I leave the room? And here was an opportunity to answer that question. People had been doing laboratory experiments and seeing how long the virus could be passed in culture, which is all fine. But what about how long does it take to infect another person?
Right. That gives us a lot of big questions to ask. So we'll start with the reversion mutation, which is the, correct me if I'm wrong, T29742G. And it's a key piece in understanding the transmission dynamics that we're looking at. Can you tell us exactly how that mutation contributed to what was observed?
So I'm not sure it did contribute, except by giving us a roadmap. The mutation is sort of at the tail end of the gene, and it's in what's called the 3' untranslated region, which means that it doesn't produce its own it doesn't produce its own protein, but it helps to regulate the expression of the other genes. So I'm not sure it was involved in being more transmissible. After all, prior to that reversion mutation, there was pretty ready transmission among the first 4 people. But what we did learn is that the first person to have that reversion mutation left their room, and a little bit more than 2 hours later and a little bit less than 5 hours later, 2 other people who came into the room, and no one else was in that room, both eventually became infected with exactly the same genomic RNA. And that suggested that this virus had been hanging around in the room, either as an aerosol or maybe on a surface, for almost 5 hours, and was still capable of infecting. And that's really what we learned from doing this genomic epidemiology.
Wow, that's a really interesting piece of the puzzle. But let's switch gears a little bit now. I'm curious about the cleaning protocols. We know that they use quaternary ammonia compounds, but without UV disinfection. What were the limitations there, and could taking a different approach have changed the outcome here?
Yeah, so hospital cleaning is very challenging and tricky, right? And
Sure
depends
is.
on so many different factors. So I think like you said, we use a standard quaternary compound, right, to clean the hospital room. So that's essentially for all surfaces to try to minimize any contact or fomite transmission of COVID. Now, of course, that's only as good as the hospital cleaning staff, but at that time, I think everyone was very focused on cleaning and ensuring that they did the best job possible, as we were right at the start of Delta. So, the UV disinfection, which is known to reduce both contact and surface pathogens as well as airborne pathogens, we typically added to a room for multi-drug resistant organisms or any known airborne pathogen. So at the time, we were not doing it standardly for other rooms, given kind of resource constraints and trying to turn over the rooms in a timely way. So I think it's a little bit unclear, but perhaps had we been doing UV disinfection in every room, we may have perhaps prevented some of these two transmission events. I think it's a little bit unclear, but we were not using it at that moment, given kind of a risk assessment for the unit.
Yeah, that's interesting. And, one of the big pieces that infection prevention, I think probably a lot of us had to learn about and take into consideration around this time was air quality.
Yep.
So one of the big questions in these scenarios is how real-time monitoring of air turnover and ventilation rates could give us a more accurate insight into airborne transmission in these hospital settings. Do you think it would make a big difference in an outbreak like this?
I think we learned that whenever you have any initial cluster outbreak, that you need to really quickly go check your ventilation rates, working with your engineering staff, because it's so important to double check that. In terms of real time monitoring and I guess 24/7 monitoring, it's really in terms of older infrastructure and resources. Perhaps there would be some high risk environments where we could use this more readily, but it's definitely something to consider. Up front, I would say that just as soon as you see first signs of transmission, just double check your rates. Very important.
Yeah, absolutely.
Yeah. And, that brings us to the classic question: how long can the virus hang out in the air and still be infectious? I mean, that's a little unsettling to think about, right?
Yeah, and I can speak to that a little bit. That's been a question that we've been struggling with since the pandemic started. Remember, right from the beginning, the question is, can it be transmitted through aerosols? And then when we said yes, the question is, how long does it stay there? And does 6 feet help or not? What are the dynamics of that? And I think it's important to understand, first of all, there's a difference between finding the virus in aerosols and showing it in an experimental laboratory condition that it can stay in aerosols, and showing actually in real life that their transmission can occur through that mechanism. And I think that's where our study is really helpful, is it actually demonstrates in real life, further supported by the whole genome sequencing, that there was likely transmission almost at 5 hours. So that's a little bit different than what we normally think about in terms of duration of transmission through aerosols in a clinical real life setting. Now, there's been experimental studies, and they've shown certainly that the virus can last in the air, up to 3 hours, even longer, but they don't necessarily demonstrate transmissibility. If you remember, there was a study in New England Journal in 2020 showing that the virus can survive on surfaces for many, many hours, up to 3 days. And remember, we were all wiping down all of our surfaces and our groceries before bringing them into the house. But really, it turned out that wasn't correlated with true transmissibility. So here, we know that the virus can hang out in aerosols for quite a while. Our papers suggest that actually there can be transmission. Now, there's many factors that impact that transmissibility. There's environmental factors, probably the humidity. There's papers and studies that demonstrate that the pH makes a difference. But then there's also the host factor, the source and what their viral load is, maybe the clinical condition of the recipient of those aerosols. So you put all of those together, and I think the answer is that we're not able to actually know the real-time risk with every single patient and every single condition. So it's important to know that it can happen, put some parameters around that to help us to have standards, and then realize that sometimes things even happen outside of those standards and outside of those parameters, which has been true with this pandemic, certainly. Thank you.
Now, for the standards that you were talking about, let's talk about, for the cleaning staff out there, what the typical process for hospital room cleaning is, and why isn't that enough in this case?
Yeah, so we follow the CDC recommendations for hospital environmental cleaning for like the terminal clean. So that, typically involves, the removal of any personal items, of all of the linens. And then there are some, items that do stay in the room. So you inspect the window treatments. If they're soiled, you remove them. But, those are typically left in the room. And then you reprocess all the patient care equipment. And then there's the cleaning and disinfection, right, of all the different surfaces. And then at our facility, we do the UV disinfection for the multi-drug resistant organisms and known COVID-19. So, hospital cleaning is only as good as the specific processes we have in place and the people who actually perform them. So, I think the cleaning of the surfaces was definitely intact, although, it may not have been perfect. But we did not use the UV disinfection in this case. So we, hypothesize that this likely occurred during, secondary to airborne SARS-CoV-2. But I guess it's possible, again, that there could have been like contact or fomite transmission as well.
So speaking of like the cleaning, this is something that has always puzzled me. And actually, we ended up making a change to our protocol as a result of the CDC stating that it was fine for cleaning staff to enter the room during the time needed for the air changes to occur, to remove those contaminants, to do their cleaning process. And in my mind, that never really made sense because you have these contaminants that are kind of in the air hanging around, but like there is some likelihood or chance that they are going to fall to surfaces. So in my mind, it didn't make sense to go in and clean those surfaces while you were waiting for what CDC is saying is this minimum air change to occur in order to remove 99% of air contaminants. What are your thoughts on that?
It's a good question.
It's a great question. And I think we definitely considered that as well. For this particular case, we did not know that the patient was COVID-19 positive because the discharged patient was not exhibiting any symptoms at the time. So, we did not actually, go to our air turnover sheet and make sure we had the allotted time between. So I don't know that it actually applied in this specific situation, but it's a good thought, right? That perhaps there could have been additional contact transmission in the setting of decreased downtime.
Yeah. So this circles back to what we can take away from these findings. How do they impact current guidelines for room turnover times and cleaning protocols? And should healthcare facilities be making adjustments based on research like this?
Yeah, and I think, that's an important question. I'd say that this is a single study and it's important. It teaches us something. It certainly teaches us about the variability of SARS-CoV-2 transmission dynamics and all the different factors that go into transmission dynamics. I'd say that it wouldn't be necessarily enough to change guidelines. It's really just a reminder that guidelines are helpful and they give you sort of probably the 95% of situations, and there's going to be the 5% on either side that aren't covered by guidelines. And so I think what Dr. Linsenmeyer was alluding to, if you have an outbreak or an event that doesn't make sense and you followed the guidance, it may be helpful then to go back and say, okay, was everything going as we expected? Was the ventilation as good as we thought? And I want to remind you about a paper. I really like this paper. Early in the pandemic, published out of Taiwan, there were 3 people in a hotel that were infected, and they were all in different rooms on different floors. And the thought was there should not have been transmission between walls and floors. But when they looked further, they found out that in fact there were problems with the ventilation, and the virus was actually not as contained as they thought it was supposed to be, by using closed rooms and closed doors. So that's really what we take away from this, is that the guidance is helpful and useful, and then you also, especially with this virus and with this pandemic, have to think outside the lines.
Yeah, I also liked the studies that talked about being on an airplane.
Yeah.
Those were interesting too. Yeah.
What was the Dustin Hoffman movie? Where the virus goes through the outbreak. It's a real outbreak kind of situation. Real life nightmares. But given how important ventilation is, what recommendations do you have for hospitals that are looking to measure and optimize air turnover rates more consistently?
Well, I think hospitals need to make sure that their ventilation is optimized. I do think that we have to recognize that there's infrastructure and resource limitations, especially as the pandemic was waning and we had so many patients to take care of. The healthcare system's really overburdened. And what we're realizing is that we have to keep it efficient. So we can't just focus on one thing. And certainly can't, as Dr. Linsenmeyer was saying, close down every room for the full UV light disinfection, for example. We have to do it in a risk-based analysis, risk versus benefit. And that's where infection prevention really comes in, is doing those risk assessments, figuring out what is the efficient way to minimize risk and keep patient flow, patient care efficient and ongoing.
So great questions all around, I think. And so wrapping this up, what do hospitals need to do differently to prevent this kind of transmission in the future? We're talking about like actionable steps to make sure it wouldn't happen again. Any thoughts on that?
Yeah, so I think, first of all, I really am very excited about all the new whole genome sequencing studies coming out, because I think these are going to really lead us, impact infection prevention in a very strong way, and really help us to find these actionable items and identify what would be the best mitigation strategies. So, my big takeaways from this in terms of, clusters and outbreaks were really, check your ventilation, know what you're dealing with. And I think, if we had the capacity to implement UV disinfection earlier, I think that would probably be smart, especially when you start to identify that you're having transmission ongoing on a unit.
One other question, since we've talked about UV a few times during the conversation, I'm just curious. There were some facilities that actually installed UV in their HVAC systems. Would you feel like that might be one of those actionable items to help reduce airborne contaminants in the future?
I think, again, it goes back to kind of your infrastructure and the resources that you have to put into it. And probably we're going to need more studies to take a look at kind of the impact of those on real world transmission.
Great. Thank you.
Yeah, exactly. The potential for COVID to remain airborne and infectious for hours, even after standard cleaning, that's kind of a wake-up call. So it's definitely clear from this that enhanced infection prevention and control measures are needed.
Yeah, absolutely. And let's not forget the role of WGS, whole genome sequencing, in tracing these transmission chains. So this is very exciting. Even minor genetic variations can reveal so much about the source of the outbreak. So to your point, Dr. Linsenmeyer, the whole genome sequencing is very exciting technology, and I'm hopeful that more facilities will actually have the ability to use that in the future.
Let me take a moment and look deep into the future. I think that people are already looking at technology that might allow us to do real-time identification of airborne viruses. And it may be that what we do is react not to an outbreak by rechecking our ventilation or increasing it, but seeing that we're detecting an increasing concentration of a virus in the air, and that we will be able to say in what room is this occurring, in what part of a building is this occurring, and be more targeted in our efforts to control airborne infections. That's coming. Maybe not this fall, but I would say in the next 5 to 10 years.
Coming to theaters near you.
That's pretty cool.
We hope.
Yeah, no, it's pretty cool. That WGS is kind of like a detective, on our microscopic level. Well, I think that's about all the time we have for today, folks, and we appreciate everybody for tuning in. Remember, always stay curious, stay safe, and don't ever underestimate the power of a good ventilation system, right? I think that, my friends, is a wrap. Thank you for joining us today. We are Nikki Shore and Jesse Swain, and this is the American Journal of Infection Control podcast, Science into Practice. Thanks for listening and doing your part to prevent infection, because remember, infection prevention is everybody's business.
AGIC Science into Practice is created by the Association for Professionals in Infection Control and Epidemiology with input from the APIC Center of Research, Practice, and Innovation, and Pat Stone and Jean Brandt at AGIC and APIC staff, Rebecca Bartles, Ria Gupta, Bobby Gulshan, and Liz Garman. We work in partnership with Human Factor and audio techs Blake Althen and Carolyn Schneer. To hear other AGIC episodes and to access information about this podcast and the field of infection prevention and control, go to our website, agicscienceintopractice.org. That's AJIC scienceintopractice.org.